denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero, per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who in effect can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an anesthesiologist and I'm proud to be an intensivist. We, intensivists, are working together to fight COVID-19. Together, we are intensive care medicine.
I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I am an anaesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist and proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
My name is Jan de Waale and I'm proud to be a surgery-trained intensivist and work in intensive care. We work together to beat COVID-19. Together, we are intensive care medicine.
Well, hello everyone and welcome to this webinar on telemedicine in the ICU organised by the ESICN and supported by Philips. My name's Ari Okola. I'm an intensive care consultant from Cambridge in the United Kingdom. I've got an interest in healthcare technology, healthcare sort of data science, and my interest in that has really been spawned by realising that therapeutics are not the only way to save lives in intensive care. One of the things about our discipline is there's a high level of potentially avoidable harm in the ICU because what we do is high risk and very specialised. And so finding better ways to practice and deliver our expertise is a really important driver potentially for improvement. Now, telemedicine isn't new. In fact, I can find references in the medical literature back to 1879. But actually, maybe adoption hasn't perhaps been quite as widespread as it could have been, except for some exciting projects, some of which we'll hear about today. But it's very interesting to reflect on how maybe the challenges of COVID-19 have meant that acutely recently healthcare has had to look at new ways of reaching patients and making our expertise stretch further in these difficult times. And so it's very timely, I think, to have this webinar, particularly today. Now, I'm not going to delay things any further, but just to say that if you have any questions, please type them into the chat box. What we'll do is we'll have our three speakers and then we'll have a round table at the end and I'll pick those questions up and try to put them into some themes and bring everything together. So with no further ado, I'd like to introduce Dr. Jennifer Fang, who's a neonatologist and assistant professor of pediatrics and also serves as the medical director for the Mayo Clinic's Tele-Neonatology program. So over the past few years, Dr. Fang has led the successful development and expansion of the Tele-Neonatology program, which serves about 19 community hospitals and provided over 500 consultations. She currently serves on the American Academy of Pediatrics section on the Telehealth Care Executive Committee, and she's going to talk to us about lessons we can learn from neonatology. Jennifer.
Great. Thank you, Ari. And thank you for the opportunity to participate in the webinar. I think, when we think about, as you mentioned, using telemedicine to really share our expertise more widely, that is really what we've been trying to do with telemedicine over the last few years to support our community hospitals when they have neonates who require, more advanced or complex resuscitation. So I do have a single disclosure, which is that I have licensed IP and can earn royalties from InTouch Health, which is now a part of Teladoc Health. So over the next 15 minutes or so, I just wanted to start by sharing with all of you what it was about the practice of neonatology and disparities in outcomes for our neonates that really drove us to develop our teleneonatology program. And then I'll go ahead and share with you how we've measured the value that our program brings to our patients through improved patient safety, patient triage, as well as the quality of care we're able to provide. So if we start with what it was that really drove us to develop our telemedicine program, again, it was really a sense of clinical need that, like many other areas of medicine within perinatology, we've regionalized care so that our high-risk pregnant women and our high-risk neonates are delivered and cared for in hospitals that are prepared to really deliver that level of care they may require. But I think as all of us recognize, that doesn't always happen. There may be geographic barriers or economic barriers or social barriers that prevent our patients from being in a hospital that they may need to be in to receive the critical care that they require. And for neonates, we know that when high-risk neonates, particularly preterm neonates, are born in a hospital that doesn't have a NICU, they experience greater rates of mortality as well as morbidity. So for our very preterm babies, we know that the odds of death are nearly 60% higher if a very preterm baby is born in a hospital without a NICU. In addition, again, greater risks of serious morbidities that can have lifelong implications for our patients, including things like severe intraventricular hemorrhage. So if we think about why is it that our neonates are suffering poorer outcomes when born in hospitals without a NICU, I think, again, this really reflects the challenge that our colleagues in these community hospitals face when a baby is born that requires advanced resuscitation. They aren't exposed to these high acuity, high complexity resuscitations very frequently. And so when they do, it may be more than what they're really prepared or managed to really deal with. And so when we look at training in neonatal resuscitation, we know that these skills actually rapidly decline within a matter of months, if not used regularly. And when we look to our providers in these community hospitals, they may resuscitate a neonate only a couple of times a year. And so again, there's this real need to how can we assist them through these high-risk situations. And obviously, an immense amount of work has been done to provide optimal care to neonates, and regionalization of care is the foundation of that. And obviously, teams practice the evidence-based and team-based approach to neonatal resuscitation. They use best practices like briefing, debriefing, simulation. Yet, this outcome disparity for our neonates persists. And this is where we looked to telemedicine to say, can we use telemedicine to leverage that expertise, that experience, that leadership that's in our neonatal intensive care units and bring that out to these critically ill babies in community hospitals. And so that led us to develop our teleneonatology program here at Mayo Clinic. And this is a network that allows our neonatologists to connect with community hospitals via a real-time audio-video telemedicine connection. So again, we can be at the bedside of these critically ill neonates when they need us. It's our 9 neonatologists that staff the 2 NICUs here at Mayo Clinic Hospital in Rochester that provide the telemedicine consults. So we started, 7 years ago as a very small pilot program with 1 hospital. And then over time, we've really learned how to improve our program, the service we offer, and we've grown and expanded to the point where we now serve 19 community hospitals in a 2-state region. And a majority of these are part of Mayo Clinic's health system, but we also provide services to 2 external sites. So I'm not sure how many neonatologists are participating in the webinar, but if we look at the reasons why we're consulted via telemedicine, these are all of the very common things we manage as neonatologists. So respiratory distress, whether that's a neonate who's having difficulty transitioning, meconium aspiration syndrome, pneumothorax. We assist very frequently with babies born prematurely, whether that may be at 23 weeks gestation or 34 weeks. And then you can see there's kind of a cluster of indications there where there's issues with concern for fetal distress, the newborn who is requiring advanced resuscitation, or there's concerns for encephalopathy and need for therapeutic hypothermia. So before I share with you how we've, again, measured the value that telemedicine has brought to our health system, I want to go ahead and share with you a short video that really illustrates how we do these consultations and how we can really partner closely with our colleagues in these community hospitals.
Today?
I'm Julie.
I'm Lindsay.
Great. Good to meet you. I understand you have a 28-week baby on the way.
Yeah, that's right. And we're just getting everything ready. We have our chemical mattress and plastic wrap. We have our Neo wrap set and ready to go. And I have intubation supply should I need it.
That's perfect.
Okay, great. Anything else? Because I think baby's about to deliver.
No, I'll go tend the baby.
Okay, all right. Okay, baby's out. Okay, we'll lift baby. Okay, we'll get monitors on. Baby's looking pretty apneic.
Puts that monitor on here.
We're just stimulating.
Looks like you're doing a good job of that. Still apneic.
Yep, still apneic.
Julie, can you check the baby's heart rate for me quickly? Sure.
Heart rate 70.
Okay, it seems like the baby is apneic, so Dr. Fang, if you could please provide some positive pressure ventilation, that would be great.
It looks like, if you could please, tilt the chin back a little bit. Tilt the head back and lift the chin. There you go. That'll help with air entry.
Yep, our manometer is looking much better now. Thank you.
And why don't you breathe a little bit more quickly than you're doing right now? So maybe 50 to 60 times a minute.
2, 3, breathe. 2, 3, breathe. 2, 3, breathe. 2, 3.
How's the heart rate, Julie?
Heart rate's still 70.
Fine. I'm not seeing very good chest rise right now, so Lindsay, can you increase the peak inspiratory pressure up to 25 for me?
Okay.
How does that feel, Dr. Fang?
We're up to peak of 25, and the chest rise looks much better. I don't know if you can see that.
No, I can. It looks good from here. I just wanted to get your take on it.
Yep, it looks much
That's
better.
great. How's the heart rate, Julie?
Heart rate's still 70.
Hi. How are the saturations?
They're 60.
Okay. Lindsay, if you could please dial up the FiO2 to 40%, and we'll see if that helps improve the heart rate.
Okay, we're there.
Yeah, and baby looks like baby's doing some breathing on his own.
Okay.
Heart rate's greater than
Saturations down,
100.
Lindsay?
They're at 72.
Okay, so coming up.
Yep.
And spontaneous breathing looks like it's starting to happen. Kind of intermittent.
It is. Yep, and Julie said our heart rate was greater than 100, so I think baby seems to be responding.
Excellent. Yeah, do you want to try some CPAP alone for right now?
I think
Keep our
so.
FiO2 where it is? Okay,
Yeah,
great.
let's try that.
Thanks for getting the temperature, Julie.
Oh, you're welcome. It's 37.2.
Perfect.
And
So it
baby's
looks like the
breathing.
baby's breathing pretty well.
Yeah, yep.
Great. So hopefully that illustrated how, again, we can so closely partner with the care team as we resuscitate a newborn, what we can see, how we can communicate, and really collaborate quite closely. So for the final few minutes, I want to go ahead and share how we've measured, again, the value that telemedicine has brought to our patients and to our healthcare system. I think fundamentally, our program has been about achieving equitable access to care. This is a map of the Mayo Clinic Midwest region. And when we think about all of the neonates born within our region, before we had our telemedicine program in place, less than half of the neonates born in this region had immediate access to a neonatologist. However, since fully implementing our program now over 4 years ago, we can say that any baby born in any of our hospitals in this region has immediate access to an expert in newborn resuscitation and critical care if needed. Another metric that we've been following is one of measuring patient safety. And this is really looking at the impact on our settled birth injury cases in our community hospitals within our health system. So I think many of us recognize that obstetrics and neonatal medicine can be high-risk areas, and thus in the US can be commonly litigated. And so when we looked at the frequency of settled birth injury cases in our health system, prior to implementation of our program, we found that we had settled birth injury cases on average about every 8 to 9 months. However, since we've implemented the program, we haven't had a single settled birth injury case in over 7 years, which is the longest period of time we've gone without a settled birth injury case in over 15 years. So again, this idea of bringing the expertise to the bedside in these high-risk situations, I think really helps these teams perform optimally and perform the standard of care. So this is looking at the impact of telemedicine on patient triage and patient disposition. This has been valuable throughout the course of our program, but really enhanced during the pandemic when we had to be very thoughtful about bed utilization, and not just within our own hospital, but within our network of hospitals, ensuring that our critical care beds are being used for neonates who require that level of care. And what we found is that after our telemedicine consults, about 1 in 3 babies is able to safely remain in the birth hospital after the consultation. So avoiding unnecessary separation of the neonate from parents, as well as being thoughtful about use of medical transport resources. So the last thing I want to touch on is how this program has impacted the quality of neonatal resuscitations. So this was a retrospective cohort study that we completed that looked at outborn neonates that were born in smaller community hospitals and then subsequently admitted to our NICU. And we compared neonates who had received a telemedicine consult to matched controls who were cared for by the local care team. And then we looked at the overall quality of the resuscitation on a 1 to 10 scale, where 1 was a poor quality resuscitation and 10 was an excellent resuscitation. And what we found was that telemedicine did significantly improve the quality of these resuscitations. The median quality rating in our telemedicine group was 7 compared to 4 in the control group. And in the graph on the right there, you can see that when we look at the percentage of neonates who received a high quality rating of 5 or greater, again, this percentage was significantly higher in the telemedicine group. When we dug a little bit deeper into the data to figure out, okay, what was it about the patients in our telemedicine group that earned them that higher quality rating, it was really performance of very important process metrics. So monitoring temperature, blood glucose and blood gas. And these are all quite critical to neonatal resuscitation. For example, we know that hypothermia during resuscitation is associated with increased risk of mortality. And we know the newborn brain, again, is very sensitive to hypoglycemia, and that appropriate ventilation is so critical, particularly in our preterm neonates. So with that, hopefully I've been able to share what it was that really pushed us to develop our program and how our program has been able to influence really patient important outcomes like safety, quality of care, and patient triage. So with that, I look forward to answering your questions during the roundtable discussion. Thank you.
Thank you, Jennifer. That's absolutely fantastic. And as I say, please keep your questions coming, and I'll try and pull them all together at the end after the 3 speakers have finished. Without any further delay, I'm going to introduce our next speaker, Christian Becker. Christian is the Associate Medical Director of Westchester Medical eHealth Centre. He's also a member of the MIT Philips eResearch Institute, and he's co-authored a wide variety of publications, particularly in the field of telemedicine and e-ICU. So, Christian, you're going to talk to us about the Tele-ICU framework from technical installs to processes.
Thank you very much, Ari. It's a pleasure to be here. I'm really looking forward to the discussion as well. Over the next 15 minutes or so, I want to share with you our journey of our eHealth Center, which got established in 2015 and then had a before, a during, and an after COVID-19 phase. And it was a little bit like the famous German soccer coach Sepp Herberger said, where he said after the game is before the game. And that's a little bit how the COVID situation feels like. To give you an idea of my healthcare network, this is a map of New York. On the bottom is New York City, on the right is Long Island, and then you can see that my system is a network of 10 hospitals that consists of a main academic medical center hub, but also has community hybrid hospitals as members, as well as actually very rural critical access hospitals. So telemedicine also for us is a question of increasing access to care and bridging access gaps between rural and more urban settings. This is a picture of our electronic ICU command center running the Philips system with eCare Manager software. It's staffed by data coordinators, critical care nurses, and a board-certified intensivist 24/7, 365. The command center also actually coordinates 16 other telemedicine programs, including tele-neonatology, teletrauma, telestroke programs, and others. So it's actually turned into a central nervous system for our healthcare network. It also integrates logistics functions for patient transfer inside and outside our network as well. This is, if you haven't seen a Tele-ICU, the way that it looks in a patient room. It's pretty standard audiovisual equipment, and then it also has a panic button or an alert button that then sets off a central alarm in the command center, and that patient room gets highest priority. This is what we've been focusing on as tasks for the electronic ICU since we started in late 2015. We routinely see each patient on admission to the ICU. We do crisis intervention, as I just mentioned. Number 3 is actually really interesting because the more recent iterations of the software employ more and more sophisticated algorithms to identify deterioration early before it's clinically evident, and it enables us to spend more time on number 3 and less time on number 2. We've had a very strong focus on standardization of clinical care delivery because we see that a small group of dedicated professionals in the electronic ICU in a most of the time calm and quiet environment can actually affect the care of large numbers of ICU patients, up to 140 patients in our case at a time. So it's an excellent tool for clinical care standardization. And then lastly, but very importantly, we actually are able to, based on Apache 4A risk predictive analyses, report out on the hard outcomes of ICU and hospital mortality, as well as ICU and hospital length of stay and ventilator days as observed over expected ratios. As I mentioned, our focus over the first 5 years has been heavily on care standardization, and we chose to focus on 5 best practices in the ICU: lung protective ventilation, transfusion practices, glycemic control, VTE prophylaxis, and stress ulcer prophylaxis. And they're all rolled into a composite best practice index. And what I'm showing you here is all academic medical centers in the United States that have the same Philips EICU support system. So these are all large academic institutions with greater than 500 beds. And we've been able to move ourselves into the top 3 for the last 3 years in a row. And that's been something that we've been able to share with all the partnering ICUs, and that's something that we're building on in terms of team building and trust building, and that's also something that we're very proud of. We recently published our before-after study, which by no means is the first, but we looked at our data from pre-implementation to post-implementation. The pre is in the light green and the post is in the dark green. And this is on the hard metrics of ICU mortality, hospital mortality, ICU length of stay, and hospital length of stay. And these are all displayed as observed over expected ratio. So you always want to beat prediction. You want to be less than 1. And we've been able, through EICU implementation, to reduce hospital mortality by 20%, ICU mortality by 27%, ICU length of stay by 21%. So this was all before COVID. And then the next graph that I'm going to show, I think probably all members in the audience have a similar graph. On the top, you see the COVID census for our main university medical center, and on the bottom, the non-COVID census. And I think the only differences for all of us are going to be when did the rise start and how steep was the incline, and when did it come down. So we were hit fairly early, not quite as early as the hospitals in New York City, but given our proximity to the city, we came pretty soon after, and we were hit pretty hard. So we actually, in early March, started a task force to look at how we can utilize our experience and our already integrated network, utilizing telemedicine to accelerate it and enhance the care for COVID-19 patients in particular. So one of the questions, again, was how to level the access throughout the whole system of our network hospitals. And this slide summarizes basically the first steps that we took. We were able to repurpose and redistribute mobile telemedicine cards and distributed them to all emergency rooms across the network. And that was with the purpose of enabling cross-coverage capabilities, load balancing at different points. We had actually large numbers of the emergency room staff quarantining in one place, so we had to really pull in staff from other locations. We were also able to quickly set up additional EICU consultation capabilities through those mobile cards. And then really the core piece was what the core team at our command center did. And so we created a centralized COVID management support team that had different functions. It actually, for one, tried to keep patients that were in peripheral hospitals in the periphery without transferring them to the University Medical Center if that wasn't necessary, but also accelerating a transfer if advanced therapies were needed. So it served as a centralized capacity management function. It also took over certain functions to alleviate resource strain on the ICU bedside teams, and that we were able to implement rather quickly. And then lastly, also, we found that it was useful to have a central entity within the network to identify patients for clinical trials and to coordinate their enrollment across the system. One piece of the centralized management was a team that specifically dealt with ventilator management. It was led by the intensivist, but had a lot of help that really quickly was able to come together. And basically what that team did is it circled through up to 130 patients that were on mechanical ventilators, and it constantly adjusted their ventilator settings, and thereby it was able to reduce exposure quite significantly, but also keep the ventilator management timely and make changes more frequent. Having an existing telemedicine system for ICU patients also in March had us think about how we could implement a similar system for the equally large, if not larger, patient population on general medical wards. And this is where we didn't have existing infrastructure, but as you can see on the left, we basically took off-the-shelf components, iPads, and basically put them on stands and then distributed them to medical ward rooms. Initially, that was not a stable situation, but when we, as shown by the red arrows, we paired them, one in the patient room and one outside, that was a much more stable situation. And we linked them up to computers at the nurses' station, as well as in the operations center, but also we had the ability for family to connect to those. And that, in the end, was a stable setup that we were able to rapidly deploy and then expand on as we got our hands on more iPads. So this was the audiovisual improvised setup for a telehospitalist program that we started. And this is a slide that shows you on the top the number of remote video safety assessments that the telehospitalist did, and you can see that it mirrors our COVID census curve. And those audiovisual assessments were quite useful, especially after hours and at nighttime when the core staff number was reduced. On the bottom, you can see the number of best practice interventions that this new telehospitalist service did, and they consisted of cohorting events, best practice interventions, as well as actually family communication tasks that were delegated to this telehospitalist. This was really implemented a lot faster than we usually plan and roll out our telemedicine initiatives, but that was by necessity. So it was a rapid performance improvement cycle, really. And what we ended up with was actually this concept where we have the telehospitalist interacting with up to 6 hospitalist teams, having the ability to video into the rooms, interfacing with the clinical trials team, but also, as we increasingly recognized, having interactions with the tele-intensivist for step up or step down of care. And so those two specialists were in the same room, so communication was really easy that way. Also, the interfacing with patient logistics and infection prevention and control actually proved to be quite central, especially as the hospital came very, very close to running out of resources. We actually, given that we were hit fairly early, we had the desire to really put out our experience and enable others to learn from what has worked for us and what has not worked for us. So we published that in the middle of August. We didn't really anticipate that for other parts of the US and for certainly other parts of Europe that they were really still pre their first surge. So hopefully this is helpful to some groups. Looking at how we're taking this to the next step, we actually, having preliminary data and a preliminary experience, we applied for a grant mechanism through the United States Federal Communications Commission, and we were awarded a grant. So we're now actually utilizing that to build out our infrastructure and hardwire more patient rooms to conduct these types of telemedicine interventions. And I want to close with an article that was published in the Harvard Business Review actually in 2012, and it was republished in May of 2020, and it just goes over the mitigation of risk in our case through electronic ICU and or telemedicine in general, and it categorizes really three types of risk. The preventable risk, those are our best practice safety optimization initiatives. The strategic risk, improving outcomes or reducing staff sleep deprivation. But then actually the third category is the one of external risk, which is really difficult to mitigate. It's very unpredictable, and COVID-19 certainly, I think everybody would agree, is a pretty classic example of external risk. So in our experience, I'm putting this slide up to show that for us, having invested in a robust telemedicine infrastructure, I think enabled us to, in some cases, be more flexible and be faster in responding to this external risk. And then I come back to the quote that after the game is before the game. So that's what I wanted to share. I really also look forward to answering questions and to more discussion in the podium discussion session.
Thank you, Christian. I think just amazing that you were able to sort of roll this out so quickly and so effectively under difficult circumstances. I'll go to the third speaker, Björn Weiss. He's a consultant in intensive care medicine from the Charité in Berlin. He's actually played a very significant role within the ICN, particularly recently with the NEXT committee. But he's also published widely in a whole variety of different fields and ICU outcomes, but also has extensive experience of telehealth process quality and implementation. So Björn, over to you.
Thank you very much for this kind introduction, and it's my pleasure to talk after these two brilliant speakers, and I think you learned already a lot about Tele-ICU. I would like to focus a little bit on the European perspective, because I know in Europe telemedicine and Tele-ICU is something much more new. It's much more established in the States. So before starting, I would like to show you my conflict of interest. Today I have no fees, no honoraria, no conflict of interest, but we got several grants here and industrial support to do our research projects. So let me start with a very, very simple question, which I always find extremely interesting. What are the intensive care challenges in COVID-19? Because it's not a very easy question to answer. If you look at the first wave in the beginning of the year, people were talking a lot about beds and a lot about ventilators. When there was summer and the first wave, at least in Europe here, ceased, and we had like this moment where we could breathe, and the second wave started, people said it's not so much the ventilators and the beds, but it's more about the stuff, especially nurses and allied healthcare professionals who run the beds. And it's not only about any kind of stuff, but it's about qualified stuff. So you need all kinds of different people. You need ICU specialists, you need a lot of nurses, you need allied healthcare professions, and all of these people are able to run a bed, to run a ventilator, and to deliver this very challenging treatment to our patients. And I think it's also very interesting to look about what was published at the very beginning at the pandemics. I would like to show you a paper of Peter Pickers, Hans van der Hoeven, and Giuseppe Citerio, published in Intensive Care Medicine at the beginning of this year. And they very clearly showed at the very beginning, and I think it's a very wise viewpoint, it's what's new in intensive care, you should read it. They said it's about the staff, about the personnel, it's about the equipment, about the beds. Of course, the beds in the first wave were a very important point, but it also about COVID-19 related emails, research idea, and non-essential information, about evolving insights, about emerging evidence, and also post-ICU care, which I have to skip due to time reasons today. So for me, it's very clear that knowledge plays an extremely important role in treating these patients, because what we actually want to do is we want to deliver the best treatment possible to our patients. And the treatment of COVID-19 patients is extremely challenging. And we have a high load of information, unfiltered evidence, we have a search, and we need to treat those patients not only at the places we are used to treat those ARDS patients. Because this is another challenge, and I asked what are other challenges, and I would like to take a look at a viewpoint from Giacomo Grasselli, Antonio Pesenti, and Maurizio Cecconi, who were heavily affected by the first wave in Lombardia, Italy. And they were looking at critical care utilization for the outbreak in Lombardia, Italy, and they talked about early experience. In my opinion, there is an extremely good and an extremely important YouTube video, an interview between Howard Bauchner, the editor-in-chief of the JAMA network, and Maurizio Cecconi. And one of the first things he mentions in this interview is that actually the network is a very, very decisive thing to look at, the network of hospitals you are working with, because nobody can take the burden alone, but we have to distribute the patients, and we have to think more in regions than in single hospitals. And this is also true in Germany. I just want to give you a very, very brief look at Germany. We have 2.1 million ICU cases per year, which makes us one of the top ICU care deliverers in the world, and we have nearly 500,000 ventilations per year. But if you look who delivers the care, then it's like 2/3 is delivered in small and medium-sized hospitals, and only 1/3 is delivered in large hospitals. And there is a very nice paper that has been published from the Nuffield Trust in 2018, and it was rethinking acute medical care in smaller hospitals. And they said we need to shift a little bit from this all or nothing principle, but we need to make hospitals part of a wider system with strong links to local services and support from other hospitals. I have to honestly admit I didn't completely understand how this support could look like, because this was in the time when we started telemedicine. But the patients we are treating in COVID are usually patients that have severe or moderate to severe ARDS. They're at a high risk of deterioration. So these are patients that are usually treated in large hospitals, or at least hospitals with a special expertise in this field. Mortality in intensive care is not a black and white phenomenon. I love to show these slides because it explains a lot of things for me. It's more shades of severity of illness coming from the absolutely non-curable conditions here at the left side and going to something you should survive. And when we look at mortality over, let's say, a 10-year period, and this is a paper from Kirsi Kaukonen and the JAMA from 2014, you see that mortality decreased and that there is a new cohort of ICU survivors, which is those people that previously have died and now survive. So what actually happened, to make it very clearly, this is at least my opinion, we shifted the survivability of critical illness from a point somewhere here to somewhere here. And how did we do that? We did that because we gained knowledge, we created evidence, and of course also we have a lot of capacity to treat these patients. So today, whereas in the 80s, for example, somebody who was over 65, it was rarely treated in the ICU. Today, it's absolutely normal to treat a person over 65, over 70 in the ICU and giving him a chance of survival, which is something that is due to knowledge. And the intensive care telemedicine program of Charité, and together with Professor Spies and our colleagues here at Charité, we developed that, was looking at an enhanced recovery after intensive care, which was before COVID, of course, but still the aim. And our aim was to prevent post-intensive care syndromes. And we wanted to implement evidence-based medicine to daily practice via a telemedical approach. And we wanted to do a post-acute treatment by ICU follow-up clinics. I don't focus on the latter one now because we don't have enough time. So we did something that is a little bit different from what we heard before. We found hospitals in the area of Berlin. This is roughly Berlin here. And in Brandenburg, which is much bigger, you see here, the hospitals in Brandenburg that make not a square, but something like a network. And we connected them via telehealth to our Tele-ICU hub here at Charité. And the speciality is, and this is what you definitely see on the right side of the slide, it was not one hospital company or one hospital network, but it was several hospital networks that joined in this telemedical program. So we have a high diversity, and we included 11 clusters and some doubles, so we attached 13 hospitals to the network, which you see here. And what we did is we did evidence-based medicine rounds, if you want so. So we used the available evidence that has been, in Germany at least, translated to quality indicators of intensive care that has been published by the German Interdisciplinary Society of Intensive Care Medicine. And we used key performance indicators that we modified a little bit to measure them on a daily basis. And we did tele-rounds at admission and then consecutively every day. And we went to these very basic ABCs. You know, we did medical rounds and defined daily targets. We did pain, agitation, delirium management, patient-adapted ventilation, weaning, etc., early nutrition. And we went through this, and we had a round and response service. So we offered 24/7 response for emergencies plus the tele-rounds. And we did this in a control and intervention phase. In the control phase, we only documented the QIs, and in the intervention phase, we did this telemedical consultation. We used a very simple telemedical device. Have in mind that we are not working in one hospital network. We have no access to the medical charts. Some are even using paper pencil based documentation. So we had to do something that gives us eyes to go to the other hospital. And we used this as a light call from Interchels, Teladoc Health. We did an EU tender and they applied for it. So we have 2 high resolution cameras with optic zoom, a dynamic bandwidth. We had a technical support and a fleet management, and it's fully disinfectable, which is more important when it comes to COVID. So the nice thing about that is I show you the data from January. This has it's really working. It's a workhorse. We had an extremely nice connection rate because connection success was almost 100%, and there were very, very few occasions when we didn't get it. And it's usually when they set up, for example, an update on their firewalls and we can't get through anymore, then we have to change some things. But it's really rarely happening. It's really a well-functioning system from a technical point of view. We changed a little bit in terms of well, we're more modern now. I give you a look at one of our workstations. This is my colleague, and this is the remote side. I don't show you the German discussion. This is our patient here. It's a simulation visit, and you see that we are now using mobile robots that can drive into the rooms. It makes it much more convenient to drive to the bed and to discuss with the consultant instead of pushing the device through the galleys. And this is what we use, and this is how it works. And I just want to show you one thing. If you look, for example, here at the ability of the device to see ventilator settings. It's very well. I hope you can see that. If you look at the ability of the device to look at pupils of a patient, you see here that's very well. And this is very important for us. It may be less important in other settings, but for our settings, it's extremely important because, as I said, we're working with a high diversity of different community hospitals, and those caregivers here have different ways of operating. So Eric was put in a randomized step-wedge cluster randomized control trial. We published it in BMJ Open. It has a control intervention period and predefined crossover points and a sustainment period. You can read that if you like to, and we hope to publish the results as soon as possible now because the data is collected. And what did we do in Berlin now? When COVID emerged, we saw the danger. I mean, this is a typical picture of Berlin here. You see a very typical situation. And of course, we have a high density of hospitals. But the problem is we also have a pretty big city. So you cannot say that all COVID cases might be equally distributed. That's an ideal imagination that never happens. But we also expect a higher case number, which we have at the moment. And we had this ERIC telemedicine network. And we also have our almost 30 years established ARDS ECMO network, the referral center, which we are not only for Berlin, but also for the region around it. And we wanted to have a containment strategy, not in terms of public health, but also in terms of containment within hospitals. And we defined level 1 and level 2 hospitals. Level 1 hospitals are ARDS ECMO centers. Level 2 hospitals are those hospitals that we defined that can treat COVID patients. We implemented a pretty advanced transportation system to make sure that all patients that are not treated in level 1 or level 2 patients will be referred to one. And we used a telemedical system on the basis of ERIC. And we attached all COVID ICUs, which is more than 30 sites now, to our Tele-ICU. We found a legal framework, GDPR. This is just one thing, but a very important thing in the EU, the technical framework and the logistic framework to make this possible. And in the first wave, which was comparatively low, we did more than 60 consultations per day in the Tele-ICU for 2 workstations. We do now more than 100. We have 9 consultants, senior staff working here. We have 28 clusters connected to the healthcare system, which increased to nearly 40 now. And we did 3,160 consultations in total in 2 months. So what did we do? We gave therapeutical advices for and against things. If we think about, for example, hydroxychloroquine or things like that, we prevented people to use this outside studies. We did basic intensive care support. We tried to get an equal distribution of patients between hospitals by implementing a COVID coordination center here. And we were making the ICU of Berlin one big ICU team. So actually telemedicine, to conclude, is supporting the local team. It supports nurses, allied healthcare professionals, and physicians on site. But it's also connecting hospitals between each other and makes sure that the burden of COVID-19 is equally distributed in the city. Thank you very much for your attention. This is just a quick picture of the team because it's not only me, it's a lot of people, a lot of leaders being involved and a lot of people working in the machine room with me together, and we try to make this a successful project. Thank you very much for your attention.
Thank you, Björn. Again, absolutely fascinating project. Perhaps I can kick off with some questions. I make the comment that obviously the human factors are really important as well in everything we do, and that can maybe be more difficult no matter how good the tech is. So a question specifically, I guess mostly for Jennifer, but anyone else wants to chip in, is do you ever get conflict, you know, in a highly charged scenario? But also for the others as well, you know, to what extent is it possible to conduct highly nuanced discussions that may be sensitive with relatives, with patients, particularly when communication may be difficult because they're critically ill? Just what people's thoughts are on those comments.
Sure. So I'm happy to start. So I think this idea of the human factors is really fundamental, actually, I think, to the success of the telemedicine support that we provide. We do a lot of work with our community hospitals to build relationships and build trust between their teams and our neonatal consultants, whether it's outreach visits to do education, skill stations, case reviews. I think that's really important because if they're not comfortable consulting you, they won't use the service. So I agree that that's really important. So conflict, we haven't run into that, I'll be honest, very frequently. I think most of the time, in a very highly charged situation, they're really looking for us to lead that resuscitation because they're so uncomfortable when a baby requires, prolonged PPV or intubation or central line placement, that they're actually looking for us to lead in those situations. So we haven't had to deal with that quite frequently. And then the third thing, communicating with families. I mean, we have done some discussions. We've had a few of our neonates, primarily extremely preterm neonates, die in the birth hospital, in the community hospital. And we've really tried to facilitate that discussion in partnership with the community hospital physician, because again, they don't share or break that kind of news with any sort of frequency. So we're able to assist with that, or, even the discussions about the need for, transfer via rotor ring to the intensive care unit, in a different hospital in a different state, being able to share that with them and have them engage with us before they actually come into our NICU has been very helpful.
Fantastic. Christian, Björn, any thoughts on this?
Yeah, I think Jennifer and Björn will agree with me that the work that's put in before any program actually goes live pays off tremendously. Any telemedicine intervention can be designed to fail if it doesn't build consensus, if it doesn't work on exactly how the workflow is going to look like, who calls whom, who has the ultimate, last word, how does conflict get resolved. Oftentimes telemedicine is at least perceived as a disruptive technology, and oftentimes it is. So it takes a lot of work to be put in before anything is implemented.
I couldn't agree more on that. I think you need a structure and you need also a legal framework that clarifies responsibility within the remote team, within the Tele-ICU team. And I would lie if I say there was no conflict. I mean, we scaled the program very fast, so we didn't have the time for preparation as we did have before. And of course, there is something like a telefatigue, or some people believe that they know better or they do different, which is okay. And when they see that you're a part, you want to be part of the team and you want to really exchange with them and you don't want to tell them what to do, which is probably a little bit different in Jennifer's program because you were definitely the expert there, but we're having a lot of peer-to-peer talk. So there is no right or no wrong, but we have to find a compromise in the end. I think that can be challenging, but I think trust-building measures and knowing the team and also liking each other, which is a very basic thing, like liking to work with each other and appreciating the work together is definitely something extremely important to make a teleprogram successful.
So on a related note, and how you actually get this off the ground and so on from a technical point of view, I mean, all of you had some pretty sophisticated tech, which I can certainly imagine looking at sort of neonatal resuscitation, if you really want to be able to see, you're going to have high quality video. But actually, Christian, I was also quite interested in that you were also rolling out some slightly more homemade, if I can call it that, solution. So to what extent is it possible to do Tele-ICU? To what extent does it really need high tech, bespoke tech? And to what extent is software, hardware available off the shelf? And if it is available off the shelf, what regulatory constraints might there be around that?
That's a great question. I think it certainly depends on what function you want it to serve. If it's a rapidly deployed crisis intervention that is focused on the moment, I think off-the-shelf technology can do quite well. If you're looking to do more sophisticated predictive analyses or do performance improvement or use it to identify areas for process improvement, then I think it just needs more interfaces, more support, and it gets more complicated as you go along. But those are not mutually exclusive. I mean, we've lived through both of those, and it was oftentimes frustrating for the off-the-shelf technology. People were taking the iPad chargers and using them for, their own phones. So we had to put big stickers on there to say, please don't do that. This is sort of a piece of medical equipment. And those were, things we just, trivial things we learned along the way.
That's really interesting. To what extent, out of interest, do you think that the American, this is something that has, is more prevalent in the US. To what extent do you think that there are differences in the way that implementations might take place, and is it transferable to Europe? Maybe this is one for Björn, maybe mainly, I guess.
Well, I think there are barriers in Europe that are not there in the US. I mean, we have EU GDPR, and for example, the technology you use has to be in compliance with that. As a little conflict, most of the really big telemedical companies that actually offer this stuff come from the US and have a different kind of approach, So patient safety is the top priority, of course, there. They have a worldwide spanning server network, for example, but we here need point-to-point, end-to-end encrypted connections. So it actually needs some kind of moving towards each other. I think using, like, for example, messengers or Skype or whatever to do telemedicine might be adequate in an emergency situation where you just need a consultation, the same, for example, as you take a phone and call somebody. But I always tell them, don't expect more, because the teleprogram itself is not about the technology. It's much more on the human side of things. You establish a deep connection, and as Jennifer showed you the pyramid, it's not only about the technology, about the robot driving through the ward and seeing the patient and having a good resolution, but it's about knowing how to do telemedicine at the bedside. It's really a skill you have to learn, and it's a little bit more difficult, I think, than just phoning each other, but it is great fun, and it can be a real resource for a team.
And it's clearly doable in Europe, as you've demonstrated.
Yes.
We're kind of running out of time. I'm going to ask one more question, sort of inspired by a question that came through from the audience, but I'm going to make it slightly more perhaps controversial to end on. So we're providing something here which is a sort of support, but to what extent can you push that? I mean, we're providing a second layer on an existing service. How far could you push that, and how far could you push expertise sort of down the line to people that really have very little experience or knowledge?
Well, I can start from a neonatal resuscitation standpoint. Briefly, I think for us, it still is always favorable to do an antenatal transport, to get the mother transported to the correct hospital, because we know those outcomes are best. We haven't done and haven't pushed comparative outcomes between, mothers or high-risk neonates in a hospital with a NICU compared to those resuscitated with telemedicine, in a hospital without a NICU. As far as how much can we push it? I mean, I still rely on the skills of that local care team, their basic newborn resuscitation skills to get a seal on the mask, to provide positive pressure, ventilation. I can't yet remotely intubate. So I think there's only so far we can go right now from at least the perspective of our program.
I can tell you, when I started this telemedicine, I started it to implement quality at the bedside and to prevent PICS. I had no clue about all of this, so I started really from zero. So our team went to the US, and we were lucky, and I saw several telemedical programs now, not only the one of Jennifer, which I heard of often now, but we visited Children's Hospital in Pittsburgh. I've been to UCLA. And when I see how they are using the technology, how this can also improve the life of workers, for example, working from home, giving consultations. I mean, you need to make sure that there is somebody who can intubate the patient. You need to make sure that there is somebody who put central lines. But on the other hand, it's the expertise, which you probably don't have at the bedside 24/7 usually, can be easily, you can easily get this via telemedicine. And if you have a robot, it doesn't say it's only me who can log on it, but it's also the neurosurgeon who can log on it. It's the cardiac surgeon. And if you don't have one in your house, you can just call him and ask him for a teleconsult, and then you have those people at the bedside. And I think it's a tremendous advantage for patients. It's a very patient-centered technology. Patients love it, by the way. 95%, I would say, love it. And it's a good thing. It gives them a good feeling, because you don't decide whether you get your heart attack in front of a university hospital or somewhere very remotely. And if you know there is an expert and they are connected and they are safe, that makes a huge difference. And it gives you a good feeling as a big team to be part of a network.
And the only thing I would add is that from a strictly pragmatic standpoint, in the US, we're faced with a supply-demand shortage of intensivists and other specialists as well. That's exacerbated by very distinct geographic heterogeneity. So to push the collaborative model of extending expertise to more remote places, as Björn said, that is a simple necessity, even if you're a skeptic of innovative technologies. It just will not work without it. So I think that also has to be kept in mind.
Thank you. No, it all resonates with me, and I have to say, it's been absolutely fascinating hearing these stories, and just reflecting on the fact that what comes through all of it is that the thing that makes people better on intensive care on a regular basis, daily basis, is doing the right thing every time at the right time, for every patient, and you can really see how these kinds of technologies can help with that and take some of the variability out of the equation. Well, anyway, I think we're out of time, so I'll call a close to the questions. I suppose all that remains for me is to thank our three excellent speakers for their presentations, which I hope the audience that have tuned in today have enjoyed as much as I have. Thank you very much.
Thank you.